It's taking a minute.
क्या प्लान करिए सुप्रिया?
नहीं, वेट कर रहे हैं, वो लाइव बोलेंगी उसके बाद विल स्टार्ट.
ओके ओके ओके.
Good evening, everyone. Good evening, faculties and delegates. This is Chitrakla from Shield Healthcare. I welcome everyone on this evening. Today, our webinar is on Wellness During Menopause Journey, organized by Patna Menopause Society. It's my pleasure to introduce the convener and organizer of this webinar, none other than Dr. Supriya Jaiswal. Dr. Supriya Jaiswal ma'am is a Joint Secretary of Patna Menopause Society, Chairperson of Adolescent Health Committee FOXY, and Vice President of Patna Obstetric and Gynecology Society. Welcome you, ma'am. And we have a scientific convener of this webinar, Dr. Jyoti Malhotra. Dr. Jyoti Malhotra ma'am is a Senior Consultant, Gurja Hospital, Patna, and Secretary of Patna PAR. Now I hand over this webinar to Dr. Supriya Jaiswal ma'am.
Okay. Thank you, Chitrakala, for the wonderful introduction of both of us. So a very good evening to each one of you who are present here today. So today is the first episode of this webinar, Wellness During Menopause Journey. This is organized by Patna Menopause Society. And as you all know, this is health is wealth. So we keep the theme. We have to see the wellness during menopause journey. So with these words, I actually welcome and bring greetings to all of you who are present, and especially Madam Ambuja Madam, Dr. Anju Soni, Dr. Kumkum De, and everyone present here. So menopause actually, it is a natural stage in a woman's life when her menstrual period ceases, typically occurring in her late 40s to early 50s. So let us discuss all about this. So to give the welcome address, may I request Dr. Kumkum Sinha Madam, who is the uh, President of Patna Menopause Society. May I have the CV of Madam Kumkum Sinha? So Madam has recently taken over, and Madam is Consultant Obstetrician and Gynecologist, Specialist Sonologist, past President of Patna OBGY Society. In 15-16, she'd been the Chairperson ICOG AICU OG 2014 Patna. Then Chairperson Scientific Committee East Zone IMS Conference. It was a wonderful conference. Then as Secretary, Fox won DK Tank Award and J. Mishra Award. Madam had been the Treasurer of Indian Menopause IMA Women's Doctor Wing, Superintendent GG Hospital, Patna City, and ACMO. Then life member of ISOPAR, IMA, many organizations, invited faculty in so many conferences, and chairperson cultural committee Boxcon 2022. That was wonderful. Madam has many accolades to her credit, and she had been doing lots of activities since she has taken over as a president of Patna Menopause Society. So, well, Madam, over to you for your welcome address.
Can you hear me?
Yes, Madam.
Can you hear me?
Yes, Madam.
Yes. So a very good afternoon to all of you. As President of Patna Menopausal Society, I extend my warm welcome to each one of you. First of all, I can't forget Dr. Anju Soni, who is the chief guest today, the president of IMS. She was so busy traveling all along, but she obliged us, she gave us time, and she said she will come. She is so positive in her attitude. Under her presidency, the Patna Menopausal Society has had activities with her in so many ways. She is easily approachable, always pleasant and smiling. She's a workaholic, and she is a very friendly person, because I have come to know her when I went to the IMS conference in Allahabad. The next great person that we have as a chief person is Dr. C. Ambuja. She's the past president of IMS. During her tenure as president of IMS, Patna Society was very active, and she took individual interest in all of us and encouraged all of us to take part in webinars and do extra works. The other persons that I feel very much honored to welcome are the star persons, the speakers of today. We have great speakers with us, among them Dr. Binal Shah. She's the past president of Vadodara Menopausal Society, the beautiful, talented, and versatile doctor. And Patna Society has already done some activities here in Plus 32, 35 Club. Already 2 or 3 meetings we have done and webinars we have done. The other star orator is Dr. Lakshmi Shikhande. She is the Joint Secretary of IMS and vibrant, energetic, and she did great works in ICOG as chairperson, and we had met her frequently in this regard. And the other speaker is Dr. Monica Jandal Singh. She is Vice President, Bhopal Society. Now, the other chair, I welcome the chairpersons of today, including myself, Dr. Aruna Suman, Dr. Nibha Mohan, Vice President of Patna Menopausal Society, Dr. Poonam Lal, Executive Member of PMS, Dr. Neelam, Executive Member of PMS, and Dr. Nutan Narayan, who is the Treasurer of PMS. I welcome the conveners of today, Dr. Jyoti Malhotra, and of course, a special welcome to Dr. Supriya, Joint Secretary, who has done all the hard works alone in bringing out this webinar in such a short notice. And of course, I welcome also our media partner on this Zoom. So I think all of you benefit from this webinar, this prestigious webinar, when we have all star speakers, and we're expecting to learn a lot from them. So over to the organizers.
Thank you very much, Kumkumdi. You are so vibrant, so lively. You make the program very vibrant with your beautiful smile, beautiful talk, and pearls of wisdom. So thank you so much for your welcome address. So now we'll move on to the lighting of lamp, because for any auspicious event we need to pray to the Almighty. So let us all join hands, all the dignitaries, for the lighting of the lamp.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं
Thank you, everyone. Now let me have introduce Dr. C. Ambuja Madam, the chief guest of today. Can I have the CV? Madam Ambuja, Professor Ambuja Madam from Hyderabad. She's the ex-professor and HOD Obstetrics and Gynecology Department, Osmania Medical College, Hyderabad. Visiting Professor, Savitha University, Chennai. She'd been the President, Indian Menopause Society in 2021 when we had a wonderful conference online. Vice President, Family Planning Association of India. Then faculty and resource person of National Board Treasurer, Society of Obstetrics Medicine India, peer reviewer of Jogi, JMA, JK Journal. So Madam has many accolades to her credit, and Madam is easily approachable, very friendly, very helpful. So Madam, we are honored to have you as the chief guest of today's program. Over to you, Madam, for your address.
Good afternoon, everybody. Thank you, Supriya, for your kind words. And hello, am I audible?
Yes.
Yes.
I'll tell you, Patna Society is so close to me. I can never forget the days which I spent in Patna along with you all, going to that revolving
Restaurant.
this thing was they really enjoyed there. Along with Shobana, she was with me. We both were there in Patna. And so nice of your good hospitality. And I thank for making me a part of this program. And this is the first of this kind that is happening. Instead of taking one topic, you have selected as a wellness during the menopause age group. That is very good. And all stars of Patna and Binal, Lakshmi Srikande, and all the other Vibha Mohan, everybody. I really thank you all and I love you all that much. I can say no other word for that one. And today's topic really is very good. I told you there are 7 pillars for the wellness of the menopausal women. All of us very much aware of it. Like so many times, all of you are speaking about the nutrition and been taking a good diet, exercise, drinking lot of water and mindfulness, appropriate supplementation whenever necessary. More than anything, it is the mental health, sleep and all. Really, I appreciate you all. And one more thing, what is very important, what is being done in our society is the Club 35, which started with Jaideep Malhotra. It was little dormant for some time, but it rebound. It started rebound from Aarti Gupta onwards, and then I'll tell you now, no boundaries. When Binal did that committee, and everybody came to know about this, and they started, oh, what is this Club 35, what is this Club 35 and all, and lot of demand for that post has started from that time onwards. Actually, I think there was little the hitch last elections. Binal wanted to continue and somebody else wanted to come. Somehow very happy to see that situation in IMS. After all these things, we are talking about this since 25 years, I can say. And we know very well that there are so many things that have to progress. We are doing a lot. But are we able to reach a person who is in the remote place, who are in need? That's what is always that comes to my mind. Whether we are doing really anything else needed from our society, that's what is the question always. So we should never forget about the dedicated menopause clinic. That's what always in mind. At least in a week, if we can sincerely take care of one menopausal woman, because menopause is not a disease. It is only how people are changing life that is happening, how they are presenting. So I still really request all of you to have a dedicated menopause clinic, at least 2 hours in a week. Not more than that. Spend 2 hours at least with 2 patients. And if you can counsel those 2 people, we'll be doing a lot of justice to them. We don't need to see a person who is in disease. These people, what they need is mental help. That's what is necessary for them to do it. I don't think it will end up there. We can talk, somebody else can talk, but they need support from home. They are living with the family. The family support is very, very essential. How do they get that family support? That's what we were thinking all the time. It's all the previous presidents, they spoke about the dedicated menopause clinics, but still it has not come to the existence. And now at least we should go to the grassroots level. where we should think of doing the Know Your Mother program. You teach the undergraduates or in the school or in the junior college level about how we should take care of the mothers or grandmothers who are passing through all these problems like hot flushes, depression, all these things are there. So how we are going to tackle them? So not only doing the programs to ourselves, though we are involving some of the, I mean, some of the non-medical people also, they are getting involved and all. I feel sincerely we should involve the students and the some of the organizations like IME and of course Foxy is already involved in our activities and like Family Planning Association of India, where they are doing a lot of SRH services. That is the sexual reproductive health programs they are doing. With that, we should be able to reach a common man so that the family support will be there for all the menopausal women. That's what I feel when we are talking about the wellness of women in menopause. How do they get that wellness is only to tackle them at the family level and the grassroots level. I think we all will think about this, what best we can do. And all stars and stalwarts are there here. They should come out with a amicable solution so that we can do something for that one. So that was there in my mind since long time. I thought we will do something much better. Of course, previously many people do not know that what is menopause, the meaning of menopause. Now we have come to the extent that there is something like club 35, something like osteoporosis. These people, they know it, but I think for a better understanding and giving a better care, we should go to the grassroots level and do something for that one. And thank you, Patna Menopause Society, for giving me the opportunity to express my feelings. Kumkum, Supriya,
Thank you, madam.
and Vibha Mohan, for everybody. Thank you and thank you.
Thank you. Thank you, madam.
Thank you, madam.
Thank you very much, madam, for all your input. You have spoken lots about these things, what we should do. You have highlighted many things that we really need to be done on grassroots level.
क्या हाल है?
Very.
There is somewhere. Acha. So then we move forward, and Dr. Anju Soni, can I have the CV? I'll just formally introduce her, and when she comes, I will take her message. Madam Anju Soni. So as Dr. Kumkum Sinha Madam has already introduced her and told us all about her laurels, but still formally I'll introduce that Madam is the chief guest of chief guest of today's program. She is the President Indian Menopause Society. She'll be for 24-25 Secretary General IMS, Governing Council member of ICOG. That also recently she's taken over, member of India CCM, Chairperson HIV and AIDS Committee. She was with me last year. I had been working with her, and she's a very vibrant personality. ICOG Excellence Award. She has got so many honors, awards, and publications to her credit. And her major achievement is Foxy Focus on Osteoporosis, editor of Viral Infections in Pregnancy. Then Foxy GCPR, Hyperglycemic and Main Pregnancy. Then many articles in books of Foxy IMS. Release new updated technical guidelines HIV positive pregnant women. So Madam is very vibrant and very hardworking and keeps on doing something or the other. Every day we see her post. She is being very, because she is traveling, so she couldn't join right in time, but then she'll be joining shortly as soon as she lands what she has promised to us. So now I hand over, just finish off with the inaugural session. We start with the first scientific session. For this, I hand over the platform to Dr. Jyoti Malhotra, the scientific convener. Over to you, Jyoti Di.
Thank you, Supriya. Am I audible?
Yes, you are.
Yes.
First of all, I want to thank Supriya. Really, it's such a wonderful program, and thank you for making a part of this program. And I've got the opportunity to meet Ambuja Madam, and so many others will join. So this is really, really nice. Thank you so much. Now, without wasting time, I'm going to invite our first chairperson. The first chairperson is Dr. Aruna Suman. I hope she's there. Dr. Aruna? Yeah. So I'm just going to introduce her. Dr. Aruna is the professor, OB-GYN and HOD also in Government Medical College, Jagtial, Telangana. She is the Joint Secretary, FOGSI 2021, and she is at present AICOG Hyderabad 2024 Organizing Secretary. She was Organizing Secretary, and she is National Coordinator, Say No to Violence Against Women Committee, and Practical Obstetrics Committee, FOGSI member also for 2024 and 25. She is South Zonal Coordinator, FOGSI 2022-2023. I think she held this post. Now, she was in 2016 and 18, she was Adolescent Health Committee FOGSI member. And then again in 2023, she was Treasurer TCOG. Again, she has got, published many articles in national and international journals. She has won many awards to her credit, like Dhira Award, IFS Award, Award of Excellency 2023, and ISSRF Award 2024. And besides this, she's TOT for National Health Mission, like Dakshata, Comprehensive Abortion Care, PPIUCD, Rashtriya Kishori Swasthya Karyakram, and Lakshya Assessor Telangana, and again National Quality Assurance Standards Assessor also, and TOT Telangana, that is, and CG Saraya CME 2023. She gave a talk on PPH in AICOG 2023. So welcome, Dr. Aruna. And our next chairperson is, I think she'll join.
Yeah, she will.
She will join. So Dr. Nibha Mohan is our next chairperson. So I know her really, she's such a sweet person. Very almost all
It's
the
okay.
So Nibha, she's consultant in Renu Maternity Center, Patna. She's treasurer Patna Ops and Gynae Society. And can we have the CV of Dr. Nibha? And and of course, she's clinical secretary SOVCI Bihar and Jharkhand chapter. She's executive council member IFS Bihar, executive council member IFS Bihar chapter, member of FOGSI State Motherhood Committee, and coordinator for. Okay. Okay, then. Thank you so much.
Thank you.
You can, I want Dr. Aruna, if she's there, to invite and, introduce the speaker, Dr. Binal Shah. If she's not, then Dr. Nibha, you can take over.
She has not joined.
Okay, Dr.
Because
Nibha.
I am in with phone only. Okay. Good evening, everyone. My regards to all respected seniors, our President, Dr. Kumkum Sinha, C. Ambuja Madam, and Lakshmi Shri Khandedi. And hello to all of you, especially Supriya, Jyoti, Nutan, and everyone. So we are going to start with the scientific session, wellness during menopause journey. So we have 3 talks. We'll be starting with the first one, the very interesting one. The speaker is none other than Dr. Binal Shah. I know her personally. She's a very dynamic and versatile member of Baroda Society. I think one of the most active member. And we have seen conducting her IMSCON at Vadodara, where we personally attended, and we knew how well is she in managing everything. Very meticulous person. So welcome, Dr. Bimal. She is, to introduce formally, she is consultant gynecologist and laparoscopic surgeon. And she's a FOGSI representative from BOX, is a national chairperson, IMS Public Awareness Committee, past president of, I think it's Baroda Ops and Gynae Society, and past president of Baroda Menopause Society, also consultant PCOS Club India. So your appearance, your everything speaks very well, very clearly. So welcome, Vimal, and she's going to talk on a very important topic, musculoskeletal health and menopause. As we know that we, the women, are spending more than 1/3 of our life in menopause. So As a doctor, it's our duty to provide best of their health to menopausal women. And we are going to listen about the very important topic, the musculoskeletal health of postmenopausal women from Vinasa. So over to you, Dr. Vinay. Stage is yours. Please start your talk.
Madam, thank you so much, Niba ma'am, for your kind words, and warm regards to Ambuja ma'am, Dr. Kumkum ji, and Dr. Supriya ji. Thank you for this opportunity. Can you see my screen?
Yes.
Yes. Yes,
Yeah,
Vimal,
I'm
it's
just making it full screen. Yeah. Is it seen on full screen now?
No.
No, not yet.
No.
Not yet.
Not yet.
Full screen.
Ma'am, no, you need to stop share and share again, ma'am.
Okay.
Ma'am.
Or else we can do one thing, Chitrakala, if there's some problem, I'll try once more. Otherwise, you can share from my side.
Yes,
As a
ma'am.
backup, I have already mailed you
Sure,
the
sure.
presentation.
I will do.
Yeah. Is it now full screen on your side now?
I think
Started,
so.
ma'am.
I think so.
Started.
It's coming.
Yes,
Yes.
it is full
Yes.
screen.
Full screen.
Yes, it has.
I'll just, I'll change the slides. Please check if it's changing.
Ma'am, please click inside the slide once and then you can change, ma'am. Yes.
Yes.
You can
Yes.
see the slide changing? Okay,
Yes,
great.
ma'am.
Yes.
So good afternoon, respected seniors and my dear friends. As the mission of Indian Menopause Society, and you can say the slogan or the mission statement, that we want our females, ourselves and our females, fit at 40, strong at 50, right? Independent at 80. So, dear friends, as female healthcare providers, it is our responsibility that we just don't want longevity in life, but we want life in those years, right? And how does this life come? It comes from independence, it comes from mobility, right? Nobody wants to have a long life in the bed, right? So, what is important is to be very much aware about what are the musculoskeletal changes which are happening in our body at menopause. We need to be alert ourselves, and also, we have to stimulate that in our patients as well and guide them from the very beginning. And here in menopause, we always keep on talking about window of opportunity, right? So it is very important that we start these things at the right time, rather than already once the bones have become brittle, once the muscles have become atrophic, then it is very difficult to revert those changes. So before that fibrosis or that rigidness sets in, you have to act well in time. So with this, I take you on this journey of musculoskeletal health at menopause. And whatever I am talking about is fitness, and it is always related to body composition, agility, and strength. I hope you can see my slides moving.
Yes.
Yes.
Yes. Yes.
Perfect. So there are certain changes which happen in our body composition. So I'm not talking about the external shape, but what I'm talking is about the internal structure of our body with aging, the changes which are happening, and its impact on the health. And the major two things which I'm going to discuss, as Dr. Supriya had asked me, is osteoporosis and sarcopenia. Right now, these terminology is not new for all the learned menopausal society members, but a quick brush up, and then also we'll discuss about various components of physical fitness, because often we just go for a walk and we say कि आज की हमने exercise तो कर ली. But I would like to enlighten and throw some light on this, that there are many various forms of exercise and what is important for which component of the body. And a little bit of motivation also I would like to give to all my dear friends, because I speak this with a lot of conviction, because I just don't speak it, but I always walk my talk. Right? So whenever we talk about body composition, the things which come to our mind is the fat, the bone, and the lean body mass, that is the muscle. Now, all these components are very, very important. And what is important is that we have to focus more on the bones and the muscles and not on the fat. And fat composition of the body should be minimal. Osteoporosis, as all of us know, is a porous bone where the bone mineral density reduces and the microarchitectural deterioration of the bone tissue happens, which results into fragility and increased susceptibility to fracture. And I very well remember that one of the panels which I had moderated with Dr. Jyotika Desai ma'am, that we had started with a statement that we all enter the world through the pelvic brim and also leave the world through that. In the sense that many females, they lose their life because of the hip fractures. And if not life, then definitely they become morbid and bedridden. So common is osteoporosis. And you can say, being female, makes us very much susceptible to this problem, that is osteoporosis. And we know that it is a silent disease and the bone loss keeps on occurring without symptoms. So it will go undetected unless a fracture happens due to some very trivial trauma. And the vertebral collapse leads to the back pain. And as you can see, the kyphotic spine and the height loss of the menopausal female. These are the difference between the cortical and the trabecular bone. Functionally also they are different. The cortical bone is mainly, it is protective and it has the distribution which is appendicular, and the location is in the outer wall of the bone is cortical bone. Inside a long bone is what you see is the trabecular bone, and its function is more of metabolic, and mainly you see it in the vertebral column. So 80% of the adult skeleton is formed of cortical bone. Now, what happens during bone remodeling? There are two major purposes of the bone remodeling, that we keep on renewing the bone continuously and we maintain the mineral homeostasis, the internal milieu of our body. There are sequential staging in remodeling, that is resorption and formation. Resorption means जैसे हम दीवार बनाते जाते हैं, formation में बनाते हैं, and resorption में we remove the extra from that. So osteoclasts are the bone resorptive cells. So it will remove that excess or old bones, and osteoblast, they form the new bones. And these are the impacting factors: inactivity, low serum calcium levels, increased thyroid hormone, that is hyperthyroidism, increased corticosteroids. So they will increase the bone resorption. And how is the bone formation augmented? It is by weight-bearing exercises. Now, whenever we talk about walking, it is definitely not a weight-bearing exercises. So I'll come to that later. Very important hormone which the menopausal females are deficient, that is the estrogen, and the deficiency of that also leads to decreased bone formation. So estrogen, androgen, they have a great impact on the bone formation, also thyroid and the growth hormones. Now there are two factors, peak bone mass at maturity, because calcium in the bone is like a bank balance. Like if you have a good bank balance, slowly after 40, definitely this balance is going to go down. But if you have a good bank balance from the beginning, then probably you will not become poor so early, right? So you have to reach the peak bone mass by the age of around 30 to 35. After that, the loss is going to happen. Plus, what you can do is that you can slow down the age-related bone loss, which is inevitable, right? So aging, as we say, is inevitable, but aging gracefully is in our hands. We can definitely slow the speed at which we are losing the bone. So mainly we have to balance the bone formation and the bone resorption, because as such, the resorption is going to take over. These are the nutritional factors which affect the peak bone mass. As we are aware, the calcium, vitamin D, India still being a sunshine country, we have a lot of vitamin D deficiencies, and we are aware about that. Also, there is a, you can say a zero figure craving. So a lot of young girls having anorexia nervosa and not taking dairy products, because teenage is the time when, they can develop their peak bone mass. So right nutrition at the right time is very important. Other environmental factors which also have an effect on this is the smoking, excess alcohol usage, caffeine, medicines. Often people having coffee or tea say कि आज का मेरा दूध हो गया, मैंने coffee थोड़ी सी डाली और दूध के साथ ले ली, but that caffeine is not allowing the calcium of your milk to get absorbed. So that is which is very, very important thing to be, taken for point. Again, physical activity, the sedentary kind of lifestyle. And sorry to say, but many of us doctors, females and doctors and gynecologists spend 80 to 90% of our time just sitting, sitting in the consulting room, going home and sitting. Often we have a lot of people to work for us. And yeah, that's luxury, that I understand that, but then definitely whatever you don't use goes for disuse atrophy, right? So physical activity is important. And then there are hormonal factors, genetic factors as well, body structure. And here where a very lean body is again a negative point for osteoporosis. So these are the other conditions. And active growth happens in the teens and the early 20s. So try to focus on having a peak bone mass then, because after that, obviously the decrease is going to happen. These are the other major risk factors where there is a personal history of fracture, or a first degree relative, or a very low body mass, or smoking, or prolonged steroid therapy. Estrogen deficiency at young age, like we nowadays see a lot of patients with premature ovarian insufficiency, Some females undergo surgical menopause, that is oophorectomy at a young age, especially the ones with endometriosis. And also very important to keep in mind that whenever we are removing the fallopian tubes during hysterectomy, we need to preserve the blood supply of the ovaries. Otherwise, even if we keep the ovaries, they are not going to function if their blood supply is not there, right? So low calcium intake, often, females are very particular about taking calcium during pregnancy because they know that it's going to, help their baby become strong. But what they forget is their own self. Frankly, they need more calcium during lactation period. During lactation, whatever calcium is being given to reaching the baby via the milk is from the mother's own skeleton. So if she doesn't take calcium supplement during lactation, at least for 5 to 6 months, her bones are definitely going to become weak. And then she'll blame the spinal anesthesia or the epidural. कि डॉक्टर साहब आपने वो कमर में इंजेक्शन दिया था वो दुख रहा है, but actually it is their calcium deficiency which is causing these problems. Again, there are examples which are increased risk of osteoporosis where they're eating disorders. Nowadays, there is a fashion or a trend, you can say, of bariatric surgeries, IBD, type 1 diabetic patients, rheumatoid or stroke, even thyrotoxicosis. Excess thyroid hormone leads to osteoporosis. So these are the drugs which would reduce the prolonged bone mass, especially for gynecologists. I would like to remind about the leupride injections which we are giving for endometriosis, or supraphysiological doses of levothyroxine. Like, please remember to always keep on checking and monitoring the TSH level whenever we are supplementing levothyroxine from outside. Overcorrection of the hypothyroid and excess dose of levothyroxine can also lead to osteoporosis. Some females, unfortunately, have to undergo pelvic radiation. At that time, the radiation to the ovaries would also result in early menopause. So we can, laparoscopically take this ovaries out of the pelvic area. Again, steroids and immunosuppressants or prolonged heparin use can lead to osteoporosis. We are aware about the primary and the secondary. Primary is one which happens in the type 1 is the one which happens in the postmenopausal females. And we have fracture sites which are very common, that is the spine and the forearm. And the type 2 is the senile osteoporosis. So mainly it is the estrogen deficiency which leads to increased bone resorption without simultaneous increase in the bone formation. So that is why we get weaker bones. And this is the type 2 where there is decreased osteoblast, so decreased formation, right? So postmenopausal, it is more of resorption in type 1, and in type 2, there is more of decrease of the formation. And type 3 is which is related to, it can happen at any age, it is secondary, it is related to some condition, medical condition. And this is type 4 is due to drug related. So this was the WHO report where they had found that T-score when we measure the bone mineral density is a very important parameter of how you can, compare that what is the bone mass index of this person, bone mass density of this person compared to a normal young control. Whereas Z-score, we match it with the age match control, right? So this is how a BMD chart shows the T-score and the Z-score, and with the aging, you can see the decline in the graph. So a normal T-score is within 1 standard deviation of a young normal. So it will be a T-score of -1 and above. Osteopenia is defined as a T-score which is between -1 to -2.5. And osteoporosis, that is a bone mineral density 2.5 standard deviation or below a young normal adult. And fractures are not diagnostic and always related to osteoporosis. It also depends on the trauma which was given. And bone mineral density is the single most predictor of the fracture risk. And with each standard deviation, the fracture risk increases by 50 to 100%. So there is no national recommendation as to which, there are two techniques, peripheral BMD and central BMD. As we are all aware, the central BMD or the DEXA is the most accurate, and you can say it is the gold standard. But what we normally use in the awareness camps is the peripheral BMD. But at the same time, as Ambuja ma'am was saying that, such camps are kind of, they initiate that interest in osteoporosis. They make people aware. So even if it is not very accurate, it is good enough to sensitize the person that, she needs to take care of her bones, right? So when is the bone densitometry warranted? For all females above the age of 65 or older, and younger postmenopausal females, especially if they have any of those risk factors which we discussed, and other females. So these are the ones who we should recommend BMD. And we already know that DEXA means dual energy X-ray absorptiometry. It is the gold standard. It is done at the hip, spine, and the neck. And peripheral DEXA, it is low energy. It is done in the forearm or finger or the heel. And this is the bone sonometry. And accordingly, we decide that, heel bone, definitely the sonometry will be different from the hip and the spine. There are 3 categories which are designed. T-score of more than 0, that is a low risk patient. Between 0 to -1 is a moderate risk. And T-score less than -1 is a high risk person. Now, how frequently you should get a BMD done? Every 1 to 2 years, depending on the age and the T-score, right? So that is the frequency you should get done. And these are the guidelines that time until follow-up depends on T-score, whether the patient is receiving any preventive therapy or a treatment therapy. So T-score more than 1.5 every 3 years, preventive therapy every 1 to 2 years, and receiving treatment, then yearly follow-up for 3 years, and then every 2 years till the bone mass stabilizes. So the primary goal is to educate, make people aware, and especially about the behavioral and the lifestyle changes. And as I already said, that we have to reach a good peak bone mass before the age of 35, and we should try to reduce the resorption which is happening by giving the person adequate calcium, vitamin D, weight-bearing exercise, lifestyle modification, and fall prevention and drug therapy. We are all aware about the dose which we have to give. In calcium, what is important is that we have to give, whenever you are giving other medical management for osteoporosis, calcium has to be adequate. Without the key ingredient, obviously you cannot make the bone strong. Yeah. Now, what is important in calcium is that besides calcium medications, the dairy product intake should also be important. Calcium tablet, approximately 30% absorption happens, and it absorbs better in acidic environment. Chewable products have increased absorption, and the citrate and the lactate salts are preferred, especially in the elderly. What is important is that maximally you can absorb around 500 milligram per dose. So it should not be given as a 1 gram tablet. Rather, it is better to give it in 2 divided doses, right? And plus, it is better to avoid the supplements which are derived from oyster shells or dolomite. Sometimes it may cause constipation, gas, and bloating. And there are drug interactions as well with the other drugs. So try avoid giving them with other drugs at the same time. And vitamin D is necessary for the calcium absorption and bone resorption. So that supplementation should also be given along with the sun exposure, right? So this is, finally a kind of a summary that we have to achieve the peak bone mass in less than 40. After 40, the bone mass is definitely going to decline, right? And this is our statement, which was from the Journal of Midlife. And it is very timely and praiseworthy that the Indian Menopause Society, has taken the initiative, because we cannot always compare our ethnic population with the European or the Caucasian population. So Indian Menopause Society has published the osteoporosis practice guidelines, especially for the management of postmenopausal osteoporosis. And it is best suited not only for India, but the entire South Asia. So this is from the Journal of Midlife. And this, to summarize, are the osteoporosis risk factors. You can remember it as excess, the mnemonic: alcohol, steroid, calcium, estrogen, smoking, and sedentary lifestyle. Now, how do we prevent it? It is by weight-bearing exercises and to improve the muscle tone, decrease the fall. Now, how frequently? Minimum 2 times a week, you have to do around 40 minutes of weight-bearing exercises, right? Or else you can reduce the time duration, but increase the frequency. That is 4 times per week for 30 minutes. So these are these are few examples of exercises which you can do. And mainly, I'll come to the video of weight-bearing exercises. Lifestyle modifications, as we already discussed, limit the caffeine, alcohol, and no smoking. Now, coming to the another important aspect of my talk, that is about sarcopenia. From the older times, the heroes used to say that, the strong person has great bones. So, and at the same time, very strong muscles. The one who can put the Ram Bhagwan, he could string the bow. And that was because of the strength of his muscles, right? So equation of strong muscles is with good health and strength. And what happens is that in human beings, first 2 decades, the muscles are built up. And third and fourth decade, the muscle loss starts happening. Now, why are we so worried about muscles? Because it is the most important element of the body composition. Greater the muscle mass, faster the energy, and higher the rate of metabolism. Now, often you must be wondering that, people who are eating even much less than you are able to burn out those calories and still maintain a proper body or a figure. Why is it so? Because their muscles, their body metabolism is very good. कई बार बोलते हैं ना, मैं कुछ भी नहीं खाती, मुझे तो हवा भी लग जाती है, पानी भी, मैं पानी पीती हूँ, वजन बढ़ जाता है. So mainly what is happening is that your body is not having a good metabolism, and that is due to less of muscles. Muscles, they reduce the oxidative stress, they maintain the mitochondria, and they manage the stress and boost the confidence. So how do we define sarcopenia? It is the decrease in the number and the size of the muscle cells. Now, fortunately, the osteoporosis awareness came very fast. The definition came, the coining of the term was there, the people started understanding the consequences, pharmacological people had interest, there was public awareness, there were criteria, there were guidelines. So in a very short time, people had a lot of awareness about osteoporosis. And frankly speaking, sarcopenia, the first time I heard this term was when Professor Dr. Rama Vaidya gave a talk in Vadodara, in the Vadodara Menopause Society. So that was the first time I came across this term. And sarcopenia, frankly, there are no medications available. And that is why pharma are not interested in sarcopenia, right? And at the same time, doctors themselves are not much aware or bothered about sarcopenia. And there is a lack of public interest as well. So that is why, sarcopenia is something which is very much, you can say neglected part of our body composition. And here is a most important summary slide, you can say, about the body composition changes which are happening with the age. As you can see, in the muscle, there is a 15% loss, from a healthy young to a senior, there's a 15% loss in the muscle tissue. There is a gain in the adipose tissue, as you can see, and there is a loss in the bone. But most dramatic is this, almost 50% reduction or decline in the muscle strength with the aging. This chart, you can see, this was a very important study where it was shown that, it was simultaneously the quality and strength also of the muscle was lost. So this is the muscle loss. As we can see, the skeletal muscle, the graph is declining. And this contributed to a lot of other problems in the female. The muscle strength, as you can see, is declining. Even in females who are regularly doing some exercise or they were doing some training, still you can see that the muscle mass is declining and the strength is declining with aging. So what happens due to cumulative loss of muscle, that there is a decreased strength, decreased exercise tolerance, thoda sa kaam karte hain, thak jate hain, सीढ़ी चढ़ते हैं, थक जाते हैं. It is related to weakness and overall fatigue and reduced ability to perform the daily activities. Also, it leads to poor balance, slowness of gaits, and fall. So sarcopenia, it alters the resting metabolic rate. And this increases the insulin resistance and glucose intolerance, because gradually the lean body mass is replaced by the adipose tissue and the fibrous tissue. And that is how, because of the increase in the insulin resistance, there is an increased chance of developing diabetes. What happens is that after menopause, it is shown that there is denervation and dropout of type 2 of the muscle fibers, and the body composition becomes predominantly type 1. Now, there is a higher proportion of estrogen receptors on the type 2. That is the fast twitch muscle fibers in the skeletal muscle. And this is the main reason that there is a greater loss of type 2 muscle fibers with age and with menopause. And unfortunately, this sarcopenia is made worse by low protein intake, very common in our vegetarian population, where the protein content is very low. And at the same time, a lot of food interactions, wrong eating habits. So the protein absorption is also not adequate, and also vitamin D deficiency. So these two things make the sarcopenia worse. Now, body composition is more accurate analysis of a person's health rather than BMI. Like, normally whenever we compare the two people, we compare just by BMI, but no, that's not the right way. So body composition is mainly proportion of fat and fat-free mass. Fat-free means muscles, bone, and the water. So how do we measure the body composition? Here in front of you, there are two females. Both have the same weight. Okay, the weight of the BMI, sorry. The BMI of this young female is 22 and BMI of this old lady is 22. Now, will you say that both are equally healthy? No. Why? Because this young girl has a fat percentage of 31, whereas she has a skeletal percentage of 26, which is very good. Whereas this lady has a fat percentage of 41, and she has a more of visceral fat and less of skeletal muscle. Sorry. So these are the changes in the body. So at the same time, you can see that the people having the same BMI can have different body composition. So definitely we label this girl as fit, whereas this lady as obese, right? So this we can see there was a SWAN study which was done, and it was found that with every year, the fat mass, it increases in menopause by around 3 kg, and the skeletal muscle is lost by around 0.23 kg. So this change happens every year. And this is the typical body fat distribution which happens. And we always call it from the pear to an apple transformation, where there is more weight above the waist, more fat above the waist. And this predisposes the female to the cardiovascular problems. So a pear-shaped body turns into an apple-shaped body, and this leads to a lot of increase in the insulin resistance. This is typically called the menopause-related central fat distribution. You can say कि पूरा ना पेट के आजू-बाजू टायर जैसा बन जाता है, right? And there was this JMH study where Rama ma'am was also an author. And in this study, it was concluded that menopause, the predictor of obesity and metabolic aberrations among menopausal females, mainly it is because of this fat distribution, which changes in menopause and leads to hyperglycemia, dyslipidemia, and hypertension. So menopause and aging leads to all these problems. And obesity and sarcopenia, both the things together, potentiate each other's effects, and more frailty and disability is brought about by obesity and sarcopenia at the same time. Now, what happens due to more fat in the abdomen? Increased risk of heart disease, insulin resistance, diabetes, hypertension, stroke, joint problems, and other things. So it is a significant risk factor of disability, and these are the impact of losing muscles. The person is more risk at falls, mobility, the weight increases, the heart health goes down, and there are more chances of diabetes and hospital complications. And this is the changes which happened in our life during the COVID also, because of the increased sedentary lifestyle. And as you can see, the hours, as you increase the hours of daily TV watching or screen time, the obesity increases. Now, weight gain is the major concern, and nobody wants to be called the Auntie J with this central fat distribution. So what is the role of exercises in preventing this? And I hope you are all ready to hear that how you can be fit and fabulous at 50. This is myself when I contested for the pageant. Yeah, so physical component fitness, we just by doing simple walking or simple yoga, we cannot say that aaj ka hamara workout ho gaya. There are 4 different components of a physical fitness. Cardiorespiratory endurance, that improves the heart and the lung functioning. Muscle strength, muscle endurance, and flexibility, 4 things together. So cardiorespiratory endurance, you can help the heart pump better, the lung breathe better, and you can do that by walking, jogging, cycling, and HIIT, right? Muscular strength is the single amount of force which a muscle can produce, and that you can increase by doing gym exercises and by weight bearing. Muscle endurance is how long you're able to hold that pose, right? So you can do that with help of dumbbells or some weights, and calisthenics, that is push-ups, planks, and curl-ups.
करना है तो कुछ शुरू बोले कि टाइम देना, टाइम नहीं।
So, how much time I have accordingly, I'll conclude. Supriya ji?
Hello.
Yeah, Supriya ji, how much time I have? So accordingly, I'll conclude.
I think the time is up actually. You can
It's
take
already
a-
up. Okay, so I'll just conclude with 2-3 more slides. Yeah,
Yeah.
so basically, as I told you, like this kind of workout, it trains your different kind of muscles and this prevents sarcopenia. Now, what is important is that don't compare yourself with somebody else. You know, you have to make your own initiation and whatever small things you can do. At the same time, flexibility is also very important because, you know, your joints have to move through the entire range of motion. So for this, yogasana is something which is a soul, a mind and body connect, and it, you know, calms down your mind, especially in menopause. So do a combination of yogasana, which is a very holistic way of life. So flexibility, agility, and at the same time do some weight bearing exercises and also go for walks. So try to, you know, entire week you should make your schedule where some or the little exercise you can do. This is a workout which you can do at home. You know, even if it's not necessary that every time you need to go to a gym, right? So these are for the abs. And even a nature walk is good where, you know, outdoor walk will help you decrease the cognitive incline and the degenerative process, and you will be more connected to nature, and the sunshine will give you the vitamin C as well, right? Swimming is also a very good exercise because there is no pressure on the joints. Dance is an excellent form of workout because it increases your, you know, coordination and it releases the happy hormones, the serotonin and the dopamine. So I would say that, you know, age is just a number and regular exercising would help build your muscles and your bones, and it is a better predictive of your own health. So move more, sit less, monitor your steps daily, exercise in the form of flexibility, endurance and weight training. Be careful about your diet, especially the protein content, reduce your carbs, take your supplements. Age is just a number. Here are few members, senior members from Menopause Society, which inspire us always. And I would like to say to everybody today that it's never too late. You are never too old to start exercising and add quality to your life. You know, you should not compare yourself with someone, and it is better that you can be better than what you were before, right? So thank you so much for a very patient hearing, and I hope I made some difference to everybody.
Of course, yes. Of course, yes, Vinay. So thank you so much for the crisp presentation of an exhaustive topic, both bone and
Actually,
muscle
Supriya ji
together.
said that, you know, because
Yes.
the time was short, but I
Actually-
wanted to, you know, kind of take
Actually,
everything.
bone and muscle both are independent. I mean, both are the a lengthy topic, but you have presented in a crisp manner, taking
Yeah.
all the points together, all points making clear. With the bones, with the muscles, regarding osteoporosis, osteopenia, you explained all the factors, how to prevent them, and especially the sarcopenia, which is, of course, for the last few years, everyone is aware about. And I think we should not blame the menopause about sarcopenia. It's the less of activity and less of the diet which accounts more about sarcopenia. So rightly you have mentioned all the activities, all the 4 factors of activity, not only walking, not only jogging, that makes more stronger muscles. And sarcopenia is just not the loss of muscle. You clearly said it's the strength of muscle which is needed, and stronger the muscle, stronger the bone also. So very clearly, congratulations, Binal, for this beautiful presentation. So thank you for that.
Thank you, Dr. Rima. Just I would like to add one comment upon it, Doctor. It was really wonderful and elaborative. Just one thing I want to say that, like, you know, after hearing your presentation, I'm too much motivated. But the thing is, I will start out, but how long I will maintain? That is the biggest hassle, you know.
Once you start getting the
Persistence is
positive
important.
feeling, now you get motivated for that. So
Yes,
the
if you
main
get
thing
the
is
result,
get
then you
started
get
and
the result,
start.
then you get if we get the motivated. result, then we are okay. We will continue.
हाँ
Otherwise, we say, "अरे बेकारी है, क्या ही हो रहा है?"
No.
Jyoti,
You'll definitely get. You will definitely
Jyoti,
get.
wonderful, Dr.
Jyoti.
Kunal, it was wonderful, and we are really privileged to have this wonderful talk with all the lovely videos. So thank you very much, and thank you, Jyoti Di.
Thank you, Supriya.
Thank
Now,
you,
please,
Supriya ji, for the opportunity. Thank you, Dr. Kumkum, madam. Thank you so
Madam,
much.
you are muted. Kumkum Di, you are muted. Dr. Kumkum Di, you are muted. Muted.
One
Jyoti,
second.
Yeah.
It was a very good presentation, I wanted to say. And she elaborated on all points. Nothing was, and we are very much happy to hear her talk.
and the videos are also
So-
very good. Video.
Very good.
Yeah.
So let's continue with the other speaker.
Yeah.
Yes.
Lovely you and
Uh,
lovely talk. Thank you.
Supriya, just
Yeah.
one comment that
Yeah.
that relates to Jyoti also. That once you start and you stop it, start again, restart. Don't think that I have failed and
Start
so I
again.
shouldn't do it. Again, restart. That is the mantra.
Yeah. Maybe we take a break, but we can restart. We
Yes,
pursue.
restart. Right.
Restart.
Thank you, Dee. I request Dr. Supriya to please continue with the next session.
Yeah, thank you, Jyoti Di. So wonderful first session. Now we start with the second scientific session. That is step-by-step guide to MHT. That's the speaker is none other than Dr. Lakshmi Shekhande Madam. And to chair the session, we have our President Patna Menopause Society, Dr. Kumkum Sinha Madam. She's the consultant obstetrician and gynecologist.
You
Past
already
president of-
introduced me.
Yes,
You
and
can-
Madam is a vibrant personality. So welcome you to chair this session, Madam. Dr. Poonam Lal, she is a senior consultant at Kurji Holy Family Hospital, Patna. DNB teacher, member Adolescent Health Committee, FOXY, chairperson Food and Drug and Equipment Committee for and POX, joint secretary IAG, and she has got many accolades to her credit. Has special interest in high risk pregnancy and infertility and endoscopy. Welcome you, Dr. Poonam Di. And I request Dr. Kumkum Sinha Madam to introduce our star speaker, Dr. Lakshmi Shekhande.
Thank you, Supriya. So we have another star speaker today, Dr. Lakshmi Shekhande. We have been known her so long because of the Foxy Association. She is the medical director of Shekhande Fertility Clinic at Nagpur, the immediate past chairperson of ICOG. She was the national corresponding editor Jogi, president Isopar Vidarbha chapter 19 to 21, and chairperson IMS Education Committee in 21-23. Senior Vice President Foxy in 2012, President Menopause Society of Nagpur, and President Obs and Gynae Society of Nagpur. So she has done so well in her career, in her all her achievements, and she has also gained a lot of awards: Nagpur Ratan Award, Bharat Excellence Award, Meru Hansotia Award. She has done over 22 orations and 450 guest lectures, many publications, and sensitized many adolescents to the adolescent programs of the society. And so she is now going to talk on a very important topic, that is step-by-step guide to menopausal hormone therapy. We know this hormone menopausal therapy has gone over so many changes, it is mind-boggling. Sometimes it was very good. We started prescribing so much, then came all these researches, and they said, no, everything is not good. Something is happening to the women. You should stop. And then all these prescriptions were stopped. And again, it is coming back because the women, they are lacking the estrogens. And to promote the estrogens, they are coming up with different power of estrogens and progesterones, new drug, and so many researches are coming on, and they are doing researches on lots and lots of women, and of course new programs also coming up, and different hormone therapy for premature menopause, post-menopause. All these things have different scopes and different drugs that are being used and promoted. And we must know what is the difference between all these things. So over to you, Dr. Lakshmi Shekhande.
What I have shared, just 1 minute. I was sharing my screen. Yeah, you all can see my screen?
Yes.
Just make it slideshow. So very good evening, one and all. And I am happy to meet respected Ambuja Madam, dear Vinal, Supriya, and all the office bearers of Patna Menopause Society. And Vinal, I must say your talk was very, very passionate, informative, and you yourself are a motivation to all of us. You really inspire everyone to be like you, fit and fine. So friends, I am talking on another aspect of menopause, that is step-by-step guide to menopause hormone therapy. Just to brief you about the history, widespread use of hormone therapy in the 1980s and 1990s, they came to an abrupt halt in the early 2000s after initial findings of the Women's Health Initiative trial were published and the study was terminated. Over the next several years, extensive reanalysis and assessment of the WHI data cast doubt about the validity of the original conclusions. In 2016, to atone the turmoil caused by the inappropriately communicated findings of the WHI trial, two WHI investigators, they published a request for forgiveness. So I hope everybody remembers the hue and cry created after this WHI study. Now there is general agreement among the guideline groups that menopause hormone therapy has a favorable risk-benefit ratio in women who initiate treatment between 50 to 59 years of age or within 10 years of menopause onset. In this population, MHT is highly effective for relief of vasomotor and urogenital symptoms, and it can prevent bone loss and fracture. Symptom relief provides additional benefits such as improved sexual function and overall quality of life. So the timing is very, very important because the timing of initiation of MHT affects the relation of MHT with the coronary risk. Estrogen may provide coronary benefit in early menopause, that is up to 10 years, but it may harm if you are starting it after 10 years of menopause. Absolute risk of MHT are lower in early than late menopause. MHT is appropriate for vasomotor symptom relief in early menopause, and MHT is not recommended for chronic disease prevention. So now a guide, that is step-by-step guide to MHT. The step 1 is you have to assess if MHT is right for this particular woman. Second step, you should know what are the MHT options. Now we have many. Third, you should know how to start. Fourth is the follow-up, and fifth, when to stop. That is also very, very important. So now let us come to the first step, that is assessment of the patient, whether she is a right and a fit candidate to receive MHT. So one should know the indications. First is vasomotor symptoms. MHT has been shown in double-blind randomized controlled trials to relieve hot flashes, and it is approved as first-line therapy for relief of menopause symptoms in appropriate candidates. The second indication is prevention of bone loss. Again, MHT has been shown in double-blind RCTs to prevent bone loss, and in the WHI also it has shown that it reduces fractures in postmenopausal women. Third indication is premature hypoestrogenism, that is POI. MHT is approved for women with hypogonadism, POI, or premature surgical menopause without contraindications, with health benefits for menopause symptoms, prevention of bone loss, cognition and mood issues, and in observational studies, it has been shown a positive effect as far as heart disease is also concerned. Now the fourth indication is genitourinary symptoms. Again, MHT has been shown in RCTs to effectively treat symptoms of vulvovaginal atrophy. Now, when we are talking of indications, we should know the contraindications before starting MHT. So what are the contraindications? Current, past or present or suspected breast cancer, known or suspected estrogen-dependent malignant tumors, undiagnosed genital bleeding, untreated endometrial hyperplasia, previous idiopathic or current venous thromboembolism, active or recent arterial thromboembolic disease, untreated hypertension, active liver disease, known hypersensitivity to the active substances which are there in the MHT, and porphyria cutanea tarda, which is an absolute contraindications. So now you know the indications and contraindications. Now it's time to know the risk factors for MHT use. Remember, every time we say that risk factor is we should not start it after the age of 60 years. I'm saying new start. She can continue. Don't start it after the age of 60 years or after 10 years of menopause. Obesity is a risk factor if BMI is more than 30, if there is insulin resistance, if she is having dyslipidemia, hypertension, diabetes mellitus, if she is a smoker, and if she is giving you personal or family history of venous thromboembolism. So the presence of risk factors does not necessarily mean that you should not start MHT, but it means that you have to be cautious before starting MHT. Remember, they are not contraindications. So now what are the recommendations for use of MHT in symptomatic menopausal women with risk factors? Now I am saying without risk factors, you are very safe. So if age is more than 60 years or she is more than 10 years since onset of menopause, for current users of MHT, that is she is already on MHT, it can be continued at an appropriate dose. That is the lowest effective dose. The effective word is very important, for an appropriate time if no new contraindications emerge. So she can very well continue with your adequate follow-up if no new contraindication is present. For new users in whom MHT is indicated and in the absence of major contraindications, treatment in this population also, you can give treatment with transdermal estradiol, either 25 microgram patch or gel, and you can give vaginal progesterone. If other risk factors are present, vaginal treatment with estradiol or estriol is preferred. Now, another risk factor is BMI more than 30. So, as elevated estrone production from adipose tissue increases the risk of proliferative endometrial lesions, protecting the endometrium with progesterone is a priority. So, the woman's willingness to make lifestyle improvement should be empowered. So, you have to counsel her for lifestyle modifications, and if there are no contraindications, you can give her progestogens. If there is insulin resistance, MHT should be recommended to type 2 diabetes, or if she is giving a family history of diabetes, as it reduces progression. So you have to see that diabetes is well controlled, but type 2 diabetes is not a contraindication to MHT. Now what about hypertension? MHT can improve the recent onset hypertension with enhanced response to antihypertensive drugs. So the option to start transdermal hormone therapy should be discussed with a cardiologist. Now what to do with a woman who is smoking? These women, they should be counseled to quit while also increasing daily aerobic exercises in order to improve endothelial function, reduce hypertension, and if relevant, reduce the risk of weight gain. But it is not easy to quit. So for those women who choose not to quit, vaginal hormone therapy is preferred. In selected cases, systemic hormone therapy may be considered, but only if the woman is fully aware of the higher independent cardiovascular risk due to smoking. In dyslipidemia, transdermal MHT is preferred. If she gives you personal or family history of venous thromboembolism, vaginal hormone therapy with estradiol or estriol is preferred. Now you know the indications, contraindications, and the risk factors. Now, before starting MHT, you should know the various options which are available. So the basics of MHT is estrogen replacement therapy for those women who are without a uterus. For those women with intact uterus, it has to be estrogen progesterone therapy. Estrogen is the primary active component of hormone therapy and is the recognized gold standard for treating menopausal symptoms, especially vasomotor symptoms. Systemic estrogens used for MHT in India are conjugated equine estrogens and estradiol valerate. So let us just see the difference between the estradiol valerate and the conjugated estrogen. Estradiol valerate is a natural estrogen, where conjugated estrogen is obtained from the pregnant mare's urine product. The estrogenic activity is the estradiol valerate contains the most active estrogen, that is 17 beta estradiol. The mammographic density, there is no effect with estradiol valerate. There is no effect on renin-aldosterone system with estradiol valerate. And as far as coagulation factor is concerned, there is no effect on factor 7. Vasomotor symptoms, estradiol valerate, it has hot flushes, severe thromboembolism, and breast tenderness problem is lower with estradiol valerate. It offers favorable lipid profile, and estradiol valerate has no effect on plasma homocysteine levels. So basically, we are preferring the natural vaginal progesterone, that is estradiol valerate, when it is coming to the estrogen component of your MHT. Now there are various routes also. You can have oral route, you can have vaginal creams, you can have vaginal ring, and you can have vaginal tablets for insertion. The impact of local estrogen is that endometrial surveillance with either transvaginal sonography or endometrial sampling is not required even with long-term use of vaginal estrogens, but it should be considered with higher doses or if there is more frequent applications. Progestogen therapy is not recommended with low dose vaginal estrogen therapy, but appropriate evaluation of the endometrium should be performed if vaginal bleeding occurs with your vaginal estrogen, because there are very limitations on the safety data of long-term use of vaginal estrogens. So now coming to the progestogens in MHT. Since chronic unopposed exposure of the endometrium to estrogen increases the risk of endometrial hyperplasia and cancer, progestogens are a part of systemic hormone therapy in menopausal women with an intact uterus. Now you have to select the best estrogen, best progestogen. So what are the progestogens which are available to you? We have androgenic progestogens and we have non-androgenic progestogens. Androgenic progestogens, we have norethistron acetate and levonorgestrel and medroxyprogesterone acetate, whereas non-androgenic are dydrogesterone and micronized progesterone. For norethistron, as you can have oral, transdermal. For levonorgestrel, we have oral, transdermal, intrauterine, and for all rest of the progestogens, they are oral route which is available. So an international expert panel's recommendation on MHT, they are saying micronized progesterone, but this study was before dydrogesterone was available as a progestogen component for MHT. So these studies are saying oral micronized progesterone provides endometrial protection if it is applied sequentially for 12 to 14 days per month at dose of 200 milligram per day for up to 5 years. Vaginal micronized progesterone may provide endometrial protection if applied sequentially for at least 10 days per month or every other day at 100 milligram per day for up to 3 to 5 years, which is off-label use. Transdermal micronized progesterone, remember, does not provide endometrial protection. Now coming to the dydrogesterone. According to this Women's Health Initiative study, the most important risk during combined hormone replacement therapy are breast cancer, stroke, and venous thromboembolism. To date, the combinations of estradiol with natural progesterone or its retroisomer dydrogesterone are the only combined HRT regimens for which large case control or cohort studies have shown that there is no increase in any of these three risk factors if progesterone is the dydrogesterone in your MHT. Moreover, due to the neutral effect of dydrogesterone on the vascular and metabolic systems, the preventive effect of the estradiol component with respect to myocardial infarction and metabolic syndrome can be maintained if HRT is started early after the menopause. Although a study with the same design as the WHI has not been performed, these results, they appear to be plausible considering the positive experimental evidence, particularly in the context of breast cancer and cardiovascular risk benefits. So the combination with dydrogesterone avoids endometrial hyperproliferation, maintains the beneficial effects of estradiol, and minimizes the most important risk known to be associated with the progesterone component of HRT regimens. Now there are different routes. You can have transdermal, patch, gel, oral, or vaginal. What is the dose and route of administration? The most appropriate dose of hormone therapy depends on the woman's phase of life, age, and general health status. Useful approach may be to start hormone therapy at a low dose, then titrate upwards to the lowest effective dose that is consistent with the woman's treatment goals. So each and every word of this line is very, very important. Now coming to starting. So you have chosen the component, which component you want to give, which estrogen, which progesterone in what dose. Now how to start. International guidelines recommends that hormone therapy should be started as soon as menopausal signs or symptoms appear, which in most women is between 45 to 55 years of age. Women who are having primary ovarian insufficiency, they require earlier and continued use of hormone therapy to protect against associated postmenopausal chronic diseases. So you have to evaluate the risk factors for MHT. In your history, you have to ask age, menstrual history, menopausal symptoms, past and current medical history, family history, lifestyle factors, smoking, alcohol, and exercise, how much she is doing, and the history of concurrent medications is very, very important. In your examination part, you have to see for body weight, waist circumference, blood pressure, blood test if indicated by the response to your questions. Imaging, again, if indicated, mammography if it was not performed in the previous year, and bone densitometry if patient is at risk for osteoporosis. So what is the practical approach? If uterus is intact, you can give oral estrogen plus progesterone, or you can give combined transdermal estrogen plus progesterone patch. If she is post-hysterectomy, you can give oral estrogen, or you can give transdermal estrogen patch or estrogen gel. Now, whether you should give cyclical or sequential hormone therapy. Cyclical or sequential hormone therapy involves daily administration of estrogen with the addition of progesterone for 10 to 14 days a month, or for 10 to 14 days every 13 weeks. So in first, this thing she will bleed every month. If you are giving every 13 weeks, she will bleed every 3 months. Any irregular bleeding and or spotting that occurs in addition to the regular progesterone withdrawal bleed can be managed by increasing the estrogen dose, as this stabilizes the endometrium. Continuous hormone therapy eliminates withdrawal bleeding and it promotes amenorrhea. It should be used only in women who are at least 2 years past their last menstrual period, as it can cause irregular bleeding in perimenopausal women due to the unpredictable residual production of estradiol by remaining primordial ovarian follicles. So now you know who are the candidates for continuous and who are the candidates for sequential MHT. Now how you will follow up once you have started. So you have to schedule a follow-up appointment after initiation of MHT regimen in 1 month to assess the treatment effect. Adverse effects of MST include bloating, breast tenderness, increased blood pressure, headaches, fluid retention, and urinary incontinence. So what to do if there is persistent vasomotor symptoms after starting MST? You have to increase the MST dose or try another formulation. If there is breast tenderness, reduce the dose of estrogen or switch to another progestogen. If there is unscheduled bleeding within the first 3 months, you should consider continuing treatment unless there is a high suspicion of endometrial cancer, as bleeding may settle with time, or you can switch to cyclical progestogen for patients who are taking continuous progestogen. You can increase the dose of progestogen, or you can switch from oral progestogen to a levonorgestrel IUCD. If there is unscheduled bleeding after the first 3 to 6 months of MST, you have to consider further investigations for endometrial hyperplasia or cancer. And if no endometrial pathology is detected, you should consider increasing the estrogen dose. So now when to stop? That is the step 5. Current use of hormone therapy can remain on treatment indefinitely, even lifelong if indicated, or at least until such time as the patient asks you to stop. Regular monitoring of MST is advised with adjustments made to the type, dosage, route of administration according to the patient's changing circumstances and treatment goals. So the key takeaways from my presentation is MST. It is the dominant therapeutic modality in our menopausal clinics. The skill lies in the ability to choose the optimal MST preparation for that given particular woman. Follow the steps before starting your MST. And the last line is the key to MST is individualization, minimum possible effective dose, early start of therapy, and adequate follow-up. So thank you, friends. Thank you so much for your patient hearing.
Thank you, madam, for your excellent and elaborate presentation. You have rightly said
एक मिनट
that,
आधे घंटा बाद कॉल कर लीजिएगा मीटिंग
that right patient is important for MST. Age less than 60 years, initiation within 10 years of menopause, and low risk healthy women who has no diabetes, hypertension, hyperlipidemia, increased risk of cardiovascular disease, they can safely take oral estrogen therapy. But patients who have diabetes, hypertension, dyslipidemia, or increased risk of cardiovascular disease, they can take transdermal MST or vaginal therapy they can take. And who have contraindication like breast cancer, risk of thromboembolic risk factor, or any liver disease, they should consider another mode of treatment, hormone therapy. And at the same time, we should discuss with the patient if there is severe vasomotor symptoms. And you have rightly said there is how to start MST, when to stop, when to follow up, this type of MST, estrogen, progesterone, this type of estrogen, progesterone. You have very beautifully explained everything. It was such a nice presentation. We came to know, although we all know, but it becomes so clear to us with guidelines. Thank you so much, ma'am.
Thank you, dear. Thank you all. Ambuja, I was sure Ambuja madam will definitely comment. Madam, I'm looking for your comments.
How can I be
just
without
looking forward.
appreciating Lakshmi? Tell me,
Ah.
how can I be without appreciating you? It's a crystal clear presentation.
Yeah, ma'am. Yes. You were just crystal clear. I was just
Crystal
waiting for
clear.
you.
And you know, each and every single word meaning.
Yeah, that was a wonderful presentation, Lakshmi
One
ma'am.
more thing I just want to tell about the dydrogesterone or the micronized progesterone. Everything is very correct. Still, we too prefer dydrogesterone only. But as far as the NAMS, that is the North American Menopause Society is concerned, it is not using the dydrogesterone. They mention only micronized progesterone. It is the Australians who promote dydrogesterone. Still, we have to wait because randomized, as you already told, randomized control studies are not there between these two things. We can't say anything because the dydrogesterone is getting more promotion because of the pharma company.
Yes.
Pharma, right. Very
And
costly
how
also.
much it is going to be like this only, we don't know. But still, they claim all the advantages what we are thinking all the time. It is the pharma advantages they are
Yes,
thinking.
yes.
But it is still not proved whether it is good or not. But as far as the Americans, North American society is concerned, still the first line is only natural micronized progesterone.
Correct.
Yeah, that's the thing.
Dr. Lakshmi
Thank you very
Shrikande,
much.
very,
Yes.
very nice talk.
Nice it was.
Thank you, madam.
Very nice talk, and with the importance that you gave to individualizing MHT for all patients, to select the patients, and then to just go on individualizing and the type of estrogen you need, the type of progesterone, the way of giving them. That was excellent. So very nice talk.
Yeah, old wine in
Kumkum?
new bottle.
Madam,
I
we
am
are
there.
very happy to have
Good
Dr.
afternoon,
Anju
everyone.
Soni, madam. Yes,
Hello.
madam.
Hello.
Yeah, hello. Good evening.
Good evening,
Who's
madam.
that?
Yeah, I can see
Anju.
Dr.
No, we
Anju
have
Soni
a
has logged in. Yeah.
Indian Menopause Society President, Dr. Anju Soni, who
Oh,
actually
she's traveling.
Yeah,
That's
she has
why.
logged in.
she has
Uh,
joined in time.
so welcome you, madam. Welcome you to the webinar. Please give your
Yeah.
blessings.
Yeah, thank you so much. And at the offset, I would like to congratulate all of you, Patna Menopause Society, especially to you, dear Kumkum. You
Thank
started
you so much.
you have started your program quite early. So congratulations to you and your team. And I'm sorry I couldn't join because I was in a flight. I just landed and I am in the car. So I thought, let me at least talk to you. And I missed every lecture. I wanted to be there, but definitely I'll listen to it. And I would also like to say that the topics chosen by you are very, very good topics, which are so essential for a practicing uh, gynecologist. And, putting light on those topics, especially musculoskeletal health, which is become so very important at this age, because we really need to work at it. We all know that whenever we talk of muscles, uh, when we don't do anything, our muscles start wasting. And especially in the menopausal age group, the muscle wasting is so fast that we don't even know when they are, almost become so less, especially when there is no kind of weight training and other things. And if the muscles are weak, then your bone health also goes are not good, because we all know that bone and muscles, they have a crosstalk between them, and each of one is important to maintain the health of the other tissue. So it is very, very important, because the word sarcopenia is a very latest word. It's only few years earlier it was founded, and then people started giving value to this word and started talking of the muscular health. So it's high time we spread the knowledge about this health and tell people that the health of bone and muscle is very, very important for this moment, because in post-menopausal age group, the bones also go very weak, and there are almost no symptoms of poor bone health. So we must act before it is too late. And a second talk, which has been given by Dr. Lakshmi Shrikande, is again very, very crucial for every practicing gynecologist. And it is definitely, I'm sure, the way you will all comment, giving your concluding remarks, that right MHT for right woman for right indication is very, very important. And looking forward to listen to Dr. Monica, and best wishes to Dr. Monica for her future endeavor. And I'm sure she will with her kind of knowledge and her enthusiasm, she would be there wherever she wants to go for future. So over to you, dear Patna Menopause Society, and thank you very much.
And
Thank
welcome to
you,
Bhopal.
madam.
Thank you, madam.
Welcome to
Thank
Bhopal.
you, ma'am.
Thank you.
Anju ma'am, Anju ma'am, we will be physically face to face with
Moni-
you. Probably.
yeah.
Madam is
So I'm in your
place.
city, dear. I'm in your city.
Yes. So, madam, I think my president must be escorting you, and I'll surely see you either at dinner time, and tomorrow, of course, I'll be there for your sessions.
Okay, okay. See you, dear. See you.
Thank
Bye
you so
bye.
much.
Thank
Bye
you
bye.
once
And
again.
best wishes, dear.
Anju
Thank you,
ma'am.
ma'am.
Of
Thank
course,
you, ma'am.
सुप्रिया का हुक्म हो जाए और कुमकुम का हुक्म हो जाए तो आना तो पड़ेगा ना भाई.
Oh, yes.
Thank you so much, Anju
जरूर
madam,
आइए.
for joining us.
Most welcome to
And looking,
Patna.
looking prettier.
Yeah, that's
I'm
what.
coming to Patna next month.
Yes, you are
Oh,
coming. Yes, madam.
most welcome.
Welcome.
Tell us the
Most welcome.
dates.
Chalo, okay, dear. See you all.
Bye bye, madam.
Oh,
Thank you.
Bye bye.
bye.
Yeah, bye.
Can we go with the third
So
session?
yes, it was so lovely to have our president Indian Menopause
Yeah.
Society. She joined and gave us the wonderful wishes. So now over to you, Dr. Jyoti Malhotra, ma'am. You start the third session.
Okay, for the third session, like we know, the speaker is Dr. Monica Singh. And to introduce and formally speaker, I would like to invite the chairpersons, Dr. Neelam. Now, Dr. Neelam is, we all know her, Dr. Neelam. She is consultant in Sadbhavna Clinic, Beta, Patna, executive member, ISOPAP, executive member, Patna Menopause Society. She was president, Patna Obs and Gynae Society from 2019-2020, vice president, Patna PAD from 2022 to 2023, and Vice President Patna Menopause Society 2022-2023. She was Joint Secretary Indian Fertility Society Bihar Chapter again 2022-2023. She is co-author of Critical Care in Obstetrics, and of course there are so many publications, books, and awareness books are there. And special interests of Madam are high risk pregnancy, safe motherhood. So our next chairperson, welcome Dr. Neelam. Now our next chairperson is Dr. Nutan Narayan.
Thank you.
Thank you, Di. And Dr. Nutan Narayan, she is assistant professor in MCH OB-GYN department. She is treasurer SR, treasurer PMS, ex-joint secretary PMS, and ex-working committee member ISOPAP. So again, she was a co-chairperson at ICOG committee 2014, and she is a co-chairperson of scientific committee Boxcon 20 also. And
That's okay, Jyoti. Thank you. Thank you,
now,
Jyoti.
so over to you all. Please introduce the speaker for today.
So, welcome, Dr. Monica Singh. So, she is the speaker for today, and I'm looking forward to hearing her talk, because mental health is very, very important along with all the physical health. And she is the managing committee member of ISR, and she was the vice president, Bhopal Obs and Gynae Committee, vice president, Bhopal Menopause Society, honorary secretary, MP chapter of ISR, and she is also the West Zone coordinator, Medical Disorders Committee, FOXY. Then she was the past coordinator of FOXY Infertility Committee and Sexual Medicine Committee, and organizing secretary of the 27th Annual ISR Conference, which was held in Bhopal last year in 2023. And she has got a lot of awards and achievements. The ISR Dronacharya Award at ISR Bhopal, State Star of Delhi ISR Award in December 2023, more than 20 international presentations in ASHRAE, ASRM, Aspire. She has contributed chapters in 5 textbooks of gynecology and ART, and she has got more than 200 national talks and presentations. She is also the convener of ISAR Perfection Series and convener ISAR FOXY Symbiosis Series.
Thank you. Thank you so much, ma'am, for the kind
Welcome,
words.
welcome, Dr. Monica. Please start your presentation.
So blessed, ma'am. You have read my CV from, top to bottom. Thank you so much for the honor, ma'am. I don't deserve
So,
it, actually.
no, no,
And
of course, I'm sure you deserve everything and more.
And it is my first virtual visit to Patna OBGY and Patna Menopause Society put together. I'll address both because both of them are very close to me, ma'am. And at the outset, I would like to thank my respected chairs, Dr. Neelam and Dr. Nutan Narayan, ma'am. And I would also like to thank the Patna Menopause Society office bearers, Dr. Kumkum Sinha, ma'am, Dr. Anjana Sinha, ma'am, our chief guest, Dr. Anju Soni, who is very much in Bhopal. She just landed, and we are going to have a fabulous program of Bhopal Menopause Society with her tomorrow. And Dr. C. Ambuja, ma'am, past president, Indian Menopause Society. Our dear convener and a person who's very, very close to my heart, Dr. Supriya Jaiswal, ma'am, the ever smiling mentor I have. She is Joint Secretary, Patna Menopause Society, as well as Chairperson, Foxy Adolescent Committee, and Dr. Jayati Malhotra, the Scientific Convener. With your permission, I'll start sharing my screen. And the stage has been set very nicely by the previous two talks, which were on sexual health during menopause, as well as the HRT, the menopausal hormone therapy.
It full screen, please.
So now we will talk about a less talked about topic, and this is menopause and mental health. Mental health is very important because this is basically a time when the woman needs a lot of care. There are changes in her body, there are changes in the family. So starting from physiology, we know it is actual menstrual pause. It is not menopause. And this is the inevitable point in every woman's life. When ovulation ceases to happen, along with that, there's a drastic reduction in the production and circulation of estrogen and progesterone, which ultimately, fall to very low levels. And the
Dr. Monica,
average.
can I say one thing?
Yes,
Please
ma'am.
put it full screen. Please
Yeah.
put your slide as full screen.
Ma'am, it's not there full screen.
No.
It's there full screen from my side. I'll just try again.
Put it in slide mode.
Okay.
So do one thing, Dr. Monica, you just stop sharing and then reshare.
Yes, ma'am. I'll do that. I'll do that. Ma'am, just tell me if you find it full screen, just let me know. Is it there, ma'am?
No.
No, it's not full.
Not full
Stop
screen,
and
but still it
Then
can
I'll
continue.
stop sharing again. I'll start sharing.
You can continue. We are able to see.
Yeah, we can
Okay.
read. It's not full.
Yes, we can see.
Yes, it's okay
Because
now.
we have very little time. We have very little time. So we should start. You should
Yes.
start, I think.
Yes. I hope.
Yes.
Doesn't matter. We can read.
No, not full screen.
Yes.
Now it's
Yes, ma'am.
better.
Yes,
Yes,
No, we
yes.
are getting it. We are getting it now.
Now it's okay.
Yeah.
Yes.
It's
Yes,
okay.
it's okay.
So, ma'am, most women actually reach menopause at an average age of 51 to 52 years. And this period can be divided into perimenopause, menopause, and postmenopause. We know that a woman is considered postmenopausal after 12 months of amenorrhea. Now, because of the prolongation in the life expectancies of women, women will be spending nearly 30 to 40% of the total lives postmenopausal. And the increased risk of major depressive disorders in the menopause transition appears in mainly those individuals, those ladies who've got a previous major depressive disorder. So, a greater focus of the clinician or the menopausal practitioner should be on recognizing these risk factors if she wants to give primary care. Now, a little bit of differentiation which I wanted to communicate is between premenopause, early perimenopause, late perimenopause, and definitely postmenopause. So, a premenopausal woman is is one with a regular menstrual cycle, with menstrual bleeding occurring in the past 3 months. But early perimenopause is marked with irregular menstrual cycles over the past year. But she still experiences menstrual bleeding within the last 3 months. Late perimenopause is said to occur when menstrual bleeding has not occurred in the previous 3 months, but it has happened in the previous 1 year. And postmenopause is absence of menstrual bleeding in the last 12 months when it is not caused by any medication, pregnancy, or anorexia. Historically, psychological distress has been, a matter of debate, especially in the high-income countries, because it was way back in 1816 that it was called something like a nervous affection of the uterus or hysteria. which was then, correlated as a typical symptom of menopause, and the women were totally ignored because it was taken for granted that the woman who is hysterical and menopausal is likely to be that only. It was then in 1959 that Blatt and his colleagues described the menopause as a rather unpleasant and possibly dangerous period of life and developed the first widely used menopause symptom checklist. The greatest challenge that we have as clinicians is that although we have got classic menopause symptoms in a patient, there is no classic patient as such. So as this woman is going through menopause transition, this period is actually called a gradual transition. She is not only getting older, but she is also losing the hormones. So there is significant overlap between the symptoms which occur due to aging and the symptoms which occur due to loss of estrogen. Perimenopause is commonly viewed as a very vulnerable period of a woman's life because she can develop psychiatric disorders, she can develop eating disorders. There is, a dissolving of the family, the children go away. She is at a loss of what to do. Her importance in her own eyes sometimes diminishes, and she starts experiencing severe symptoms. So there is a significant and lasting effect on the older woman's mental health. And here the QOL, the quality of life, also has to be considered. As I told you, there is estradiol variability. There is also low progesterone concentration, and there is also a change in the ratio of testosterone to estradiol, which has been associated with an increased risk of depression. Moreover, how is her psychosocial and cultural molding? This shapes mental health over menopause. Negative expectation and attitudes towards menopause. Suppose she's seen a friend or a family member or even her relatives or mother going through a rough patch of menopause. This will aggravate perception of even minor symptoms as major symptoms. The type of menopause, whether it is natural or surgical, and timing of menopause also influences the risk of depressive symptoms. And surgical menopause from bilateral oophorectomy has got a greater risk of leading to mental symptoms and depression than hysterectomy alone. Now, what is important in all these is the presence and frequency of vasomotor symptoms. These are bidirectionally associated with depression. Some women are very much bothered by vasomotor symptoms, and others are, not that much bothered, especially the ones who are busy in their work or profession. So this is directly related to mood, stress, and the degree of sleep disturbance. And it is the extent to which vasomotor symptoms are deemed as problematic or interfering with daily life, which will, determine how depression or mental changes develop in these women. Now, this is a busy slide, but I'll only focus how to detect and treat depressive symptoms and major depressive disorders during this menopause transition. Now, sadly, the Menopause Society is doing a brilliant job in training practitioners, and I just completed my CIMP, so I am very confident about the whole procedure and how the training. But there are very few general gynecologists who feel adequately prepared to address menopause, despite recognizing the importance. So the gynecologist, he or she should understand the association between menopause and mental health and be, properly trained to evaluate and manage mental health disorders and take care of that aspect of midlife care. Psychosocial interventions have got a big role to play in menopausal transition. There should be a personalized framework. Now, suppose, coming to column 3, suppose she's got depression. It should be treated as any other depression at any other life stage within a personalized framework, which has to consider the previous history that woman has, hormone sensitivity, psychosocial and menopause-related factors in the cause, recurrence, and maintenance of symptoms. Just don't ignore the woman just because she is menopausal. And effective options for major depressive disorders should be instituted in the form of psychotherapy, sometimes antidepressants, and interventional psychiatric approaches. Data has shown that there is no compelling evidence that the risk of anxiety, bipolar disorders, or psychosis is universally elevated in all women undergoing menopausal transition. Therefore, potentially attributing the psychological distress and psychiatric disorders to menopause could harm women because sometimes they actually have a physical or physiological condition. In that case, if you attribute the disorder to menopause, it may delay accurate diagnosis and the initiation of effective psychotropic therapy might be delayed, and it may create negative expectations from other people who are approaching menopause. Therefore, a paradigm shift in our thinking and tackling of menopausal patients suffering from mental health issues is required. And good mental health practices is also been defined by WHO as health promotion is a process of enabling people to increase control over and improve their health. And this control has to be in the hands of the menopausal woman. For people who are at risk of depressive symptoms during the period of menopause transition, you have to also address certain modifiable risk factors. You have to rule out whether that woman is taking adequate sleep, whether the troublesome vasomotor symptoms are causing lack of sleep, whether she's having any other family stress or exposure to stress which is causing negative attitudes towards menopause, and whether her aging is proceeding in the normal sequence or not. So the spectrum of disorders you can see, they could be mild depression, there could be a major depression, there could be just plain anxiety over even small issues in her life, just tear her apart. She's not able to deal with it. Sometimes there are bipolar disorders when she behaves in a certain very nice way on one day, the other day she's just bundle of nerves. There could be a schizophrenia spectrum, and it could lead to even suicidal tendencies. So, what is the prevalence of this depression and anxiety during menopausal transition? Now, this is, we know, is a very big window of vulnerability for developing psychiatric disorders and eating disorders, and this associated with the loss of bone mass, muscle mass, diminished exercise, binge eating. So the quality of life definitely suffers. And I cannot enhance enough the importance of exercise, because exercise not only will make her busy, it will also make her tired. She'll be able to sleep better. Her value of her own body increases. Her bones are better. So another form of therapy is MBSR. MBSR actually means mindfulness-based stress reduction. This is actually an 8-week group intervention program which is designed for similar age women to ameliorate their stress through mindfulness, meditation, and yoga techniques. Another therapy is CBT, or cognitive behavior therapy. This is another proven intervention for depression for all life stages. So basically, what is cognition? It means talking therapy. Here, the woman is talked to by a psychotherapist, and that psychotherapist or psychoanalyst could be the gynecologist also. And she is basically it is explained and filled into her that she can manage her own disorder, her own menopause, by tackling it in a logical way. So she starts thinking of her vasomotor symptoms as something she can deal with. So her mind is trained in such a way that she starts managing her symptoms. So these psychological interventions such as MBSR or mindfulness therapy shows promise for prevention, and the cognitive behavior therapy can reduce anxiety and depressed mood together with substantial reduction in the vasomotor symptoms. And here the primary care providers and community health educators can also contribute to improved health care with the help of helpful health messaging using social media, using Instagram, and certain evidence-based practices. And sometimes it is the celebrities which also inspire us. Sometimes you see a celebrity like Malaika Arora or somebody, they are above 50 and they are so fit, they are exercising, or our celebrities and gynecologists like Beenal Shah. So they motivate us, they motivate us. Like today only, after seeing Beenal's videos, I thought I must start going to the gym again. So there are important articles in these, good journals, highly read journals like Lancet of 2024. They have published online that how can you promote good mental health over menopause transition, and it's a must read. Now, is there any role of menopause hormone therapy? Notwithstanding what Lakshmi ma'am has said, MHT can improve concurrent depression symptoms for patients with bothersome vasomotor symptoms, but it cannot be taken as a primary approach for depression. And it is not an approved treatment for depressive symptoms per se. But still, some organizations, some societies suggest that we should consider MHT to treat depression during menopause, especially in the transition period, if there's nothing better to do. Similarly, the use of transdermal estradiol and micronized progesterone, we just had a discussion about dydrogesterone. So RCTs have been done with it. 12 months of transdermal estrogen and micronized progesterone were used in menopausal women, and these found to be more effective than placebo in preventing and the development of significant depressive symptoms in early and postmenopausal women. So this is a very important slide, which you can even take a screenshot. So this shows you the two blocks in pink, which increase the risk of depressive symptoms. On the left is the menopause-related risk factors, which you can't really alter much, like early menopause, surgical menopause, long period of menopause transition. Like I personally, I've been having hot flushes in last 5 years and they don't go. So I have to just deal with it. Sleep disturbances, frequent or severe nocturnal vasomotor symptoms, sex steroid variability. Now, they're established psychosocial risk factors. So, this woman has basically had a lifetime history of depression and some adverse childhood experiences. So, she's a nervous woman. She's had stressful life events like early loss of her spouse or some malignancy in the family, financial difficulties. Like the last thing a menopausal woman wants is to be she dependent or not having enough money for herself. Living in a advanced country with a minority status, living in a foreign country, she's unemployed, she's dependent, she doesn't have a social support, she loses her mother who she's very attached to, she's obese, or all these things can lead to established psychosocial risk. But there are some potentially modifiable protective factors in blue. Like you can treat the vasomotor symptoms, you can start CBT, you can start cognitive therapy, you can inculcate yoga, which doesn't cost a single penny. Treatment of sleep disturbance, positive attitudes by similar group, social support, healthy lifestyle, and psychological resources like stress management, coping strategies, and positive. Basically, you have to build a very positive self-image. So coming to the end of my talk, you have to identify the modifiable risk factors in order to bring about prevention. Managing troublesome vasomotor symptoms and sleep disturbance can reduce the risk of depression. So vasomotor symptoms and sleep disturbances, if they are tackled, what I understood is you can also tackle depression. Effective pharmacological and non-pharmacological interventions for vasomotor symptoms should be given and they should be prescribed to the woman, and evidence-based information promoting more positive or neutral attitudes towards aging. The woman has to be told it's neutral. I visited my sister in the UK, and she has a neighbor who was 80 10 years back. Now she's 90, but she stays alone. She looks after her garden. She's got a dog, and she's lost her husband 40 years back. And still, I ask about her every year, and every year she's even cooking for herself. So increasing social, of course, those countries also have a lot of social support, physical activity. They do gardening and everything. But slowly and slowly, this is coming in India also. Psychological resources, you have to inculcate into her optimism and healthy self-image because they are highly protective of mental health during menopausal transition. CBT, I've already talked about. And in summary, women with previous major depressive disorders are always at elevated risk of recurrence during menopause. So these are the women you have to target and basically tackle at the right time. Provide individuals with evidence-based information about menopause and clear statements that most individuals are not at risk of mental health problems. It is just a normal transition. But be aware of those women who are at risk and major risk conditions and treat the modifiable conditions. Do not automatically assume that psychological symptoms are attributable to menopause. Try to investigate and manage these symptoms as you would do in any other life stage. Even a child of 18 years, my daughter, when she was appearing for NEET, she was depressed. And in first year, first prop, she was in a hostel, she got depressed. She was an antidepressant for a year. But I treated her, as logically as a mother I could. Be cautious about discontinuing active treatments for major depressive disorders over menopause transition. Because if you suddenly, stop the antidepressants, the condition might worsen. Always take history into account. Challenge the assumptions that menopause transition confers universal risk for depression. It's not so. Learn from societies, the first world countries, where aging in women still confers her status and in which views of menopause are more affirming. Model empowered views of menopause and women's aging in order to cultivate more positive attitudes at the society level and promote gender equity and safety across the whole lifespan of the woman. Because if she faces adversity early on in life, it increases the risk of poor mental health at her midlife. Thank you so much for a patient listening. I invite you all to National VP Conference at Bhopal, West Zone Vice President Conference, being hosted by Bhopal Obstetrics and Gynec Society on 12th, 13th, 14th of July 2024 at the beautiful Heritage Hotel of Januma Palace. And I also ask for your blessings for my candidature as Chairperson Perinatology Committee in Foxy this year. Thank you for the opportunity, Supriya ma'am.
Thank you, Dr. Monica Singh, for a very nice talk. We had, first of all, I would like to thank Dr. Supriya and Dr. Kumkum Sinha for giving us this opportunity to be the chairperson in such a lucid talk. It was really a very good CMA from menopausal, starting from musculoskeletal health to MHT and then to menopause and mental health. Mental health is the most neglected part in the menopausal clinic. And as you rightly said, that 30 to 40% of life we spend in menopause now, and emptiness syndrome and all these mood stresses, they decrease the quality of our life. And then we got menopausal symptoms like vasomotor symptoms, and then menopause, and then depression, and all these are many people. I mean, in society in general, they attribute this to menopause, but it is rightly said that it is not. It should not be like that. We should address it, especially for the modifiable factors like sleep, BSM, stress, aging. These should be addressed and modified by other doctors, by us, and in menopause clinic. And certain things like MBSR and CBT and social media, even exercise. Exercise, among everything, exercise is the most important thing, which we should always prescribe to our menopausal ladies. And so it is such a nice, everyone should do exercise. Otherwise, it is going to be a land trouble. And MHT, apart from that, MHT can improve the symptoms, but social support, physical activity, especially hobby, optimism, these are all very important things which we should inculcate our lives, and we should advise our patients also to inculcate in their lives so that they can be their menopausal life should be happy. So thank you all, and thank you, Dr. Anju Soni, for being there, and Dr. C. Ambuja. It was nice to see you all.
Actually, Dr. Monica, we also say that this exercise and depression, they are very interlinked. Like when you exercise, then you have a lot of endorphins are released, and these, they uplift the mood. But if you are depressed, you will feel that you don't want to exercise. So there it is all interdependent. So this circle has to be broken somewhere.
So I just want to say one thing, just one thing. This depression, it is not only with menopause, even with uterus. Like if they lose the uterus after hysterectomy, so many questions. Madam, ye ho jayega, madam, wo ho jayega. So hysterectomy itself, it is with depression only. They go into depression after hysterectomy also.
Yes.
Dr. Monica Jindal Singh, it was such a nice presentation. We came to know about so much about mental health. the main thing that strikes me, we need compassion for all those women that are going for mental illness and not, they are suffering so much. And we need so much compassion. This message should go to the family members. They need support. And a support, only a loving hand can pull them out of their depression. And the drugs and other environments and social things are also there. All the support system must act. So thank you for a very beautiful presentation.
Dr. Monica.
Yes, ma'am.
Excellent presentation. And overall, what information you gave is really good. The social well-being is very important.
Yes.
Social activities and dancing. And what I found is especially in North India, people are so lovely. They get onto the stage and dance. Means that is what is the one which is giving lot of encouragement and to them. But we South Indians, we are always very much ashamed. We stay back and all. Maybe that is why we are not very forward or anything like that. So encourage people to dance, to exercise, and have the social movement. What do you say, Neelam?
Yes.
That's what.
Yes, Dr. Ambuja, you're right.
Yeah.
Not
We
even
had a word from Madam
they
Anju
put the
Soni.
hand anywhere. Yes.
Madam Anju Soni is also joined us. Madam Anju Soni.
One minute, I'll finish it off. When I came to Bhopal, on to the Patna, what I found is people are jubilant. Maybe that is the one which makes everybody psychologically fit. So thank you very much, Monica, for your wonderful talk.
It's me, no pause. It is me.
Yeah. Dr. Monica, it was really very
congratulations.
Thank you, ma'am.
Monica, congratulations for beautiful talk.
Thank you, Anju,
And
ma'am.
you pointed out most important things. And I think all of us should come forward and we should talk to the woman. Even if she comes for some other problem, we must focus on her mental health from our side. That is our job, to look into their health, So very well said, and congratulations to all of you once again.
What you said is very correct. Whatever reason they come to us, we should talk to them about their mental health.
Right.
Then only they come out of their problem. You are very
right.
So now I request Dr.
Supriya,
the vote of thanks.
Yes.
vote of thanks,
Thank you.
Supriya.
Thank you. Thank you, Supriya. Thank you for this. And it was an amazing webinar. And I thank Dr. Anju Soni for joining with all her travel plans also. Yet she has joined. And Dr. C. Ambuja, they have given really good inputs in this. And I thank all the speakers. Dr. Binal Shah for a talk on very pertinent topic of musculoskeletal health. Dr. Lakshmi Shrikhande also gave a very illuminating talk on the confusing topic of MHT. And also Dr. Monica Jindal Singh, she has given this for mental health, which we are all very thankful, and we will naturally ask everybody now about their mental health also. And also I thank Dr. Kumkum Sinha Madam. She is the president of Patna Menopausal Society. And I think Dr. Anjana Sinha has not come. She's the secretary. And Dr. Nibha, who is the joint secretary. Dr. Supriya Jaiswal, she is the joint secretary PMS. Dr. Jyoti Malhotra, she is a very senior consultant. Dr. Aruna Suman, she is the past joint secretary of FOXY. And Dr. Poonam Lal, and my dear Dr. Neelam, she is my guide and guru. And for this, I also take the opportunity to ask for Dr. Nibha Mohan is now contesting for the Food and Drugs and MSc Committee, FOXY. Please, everybody support her so that we can have one of them.
Best wishes, madam.
Best wishes.
Yes,
I would like to have just one comment in the end, that for that everybody should, for good mental health and physical health, everybody should join Dr. Anju Soni's Sunday's dancer size program.
Yes.
7 to 8 a.m. which is
Many
there.
times we do that, but not every day.
So we all should join it and be fit.
Yes.
Dr.
So I
Supriya?
thank all.
Yes, madam.
Yes, I also thank
Hello.
all the people who have joined, and I hope they have learned something from it and they will go and practice this. So, Supriya,
Thank you.
I think
Thank you for the
thank
opportunity.
you very much.
Thank you for the opportunity, Patna Menopause
So
Society.
we don't want to go, but we have to go.
Yes. But I'm really happy to have this webinar, Kumkumdi. It was wonderful. All the talks were so nice, and
I
Dr.
know.
Monica, Dr.
Yes.
Lakshmi Shikhande, they are one of the very good speakers.
Such a Kitna speaker, every point wise, they really didn't waste a single line. Every line was
Yes.
important.
Every
Right.
word, every line.
Every word, every line was important. Not a
And
single
all,
line going anywhere.
Kumkumdi, thank you.
Lakshmi ma'am is my teacher, ma'am.
Yes, she has to be. She's an ICOG, no? I think she is teacher to all of us now. Doing such good.
Always such an inspiration, ma'am.
Really, really. And Kumkumdi, it was a good, very good
Huh?
webinar. Thank you for encouraging me to start this, to do it this time.
Really, we had 3 hectic days.
Yeah.
In 3 days, we have done this webinar. Can you
Yes.
believe anybody?
Wow.
I just
wow.
told her to go on, go on, go on.
Yes.
Many speakers
Only
are
you could have done it.
putting out.
And thanks to Chitrakala, the Shield Connect, who has really helped us in doing
Yes.
everything. The lovely person she is. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you. and
Supriya,
bye-bye.
thanks for organizing so beautifully. Supriya, you did a creditable job. हम लोग का
Let's-
IMS पर एकदम प्रोजेक्ट कर दी.
Thank you.
let's have another one soon only.
Let's
Yes.
So thank you very much.